Which mechanism underlies T-cell mediated rejection in organ transplantation, and how can this process be mitigated? Discuss the roles of HLA matching in immunosuppressive therapy in managing rejection risks. Answer: T-cell mediated rejection occurs when the recipient's immune system recognizes the donor organ as foreign, primarily through mismatched major histocompatibility comp MHC or human leukocyte antigen HLA molecules. Mechanism: direct pathway. Donor antigen presenting cells acts directly activate recipient T cells. Indirect pathway. Recipient APCS process donor antigens and present them to T cells. T cells initiate cytotoxic responses and recruit inflammatory cytokines, damaging the graft. Mitigation strategies. HLA matching reduces alloimmune response by matching donor and recipient antigens, especially HLA A-to-SHA-B and HLA-Dr. loci. Immunosuppressive therapy. Drugs like calcineurin inhibitors e.g. tacrolimus, antiproliferative agents e.g. mycophenolate mofetil, and corticosteroids prevent T-cell activation and proliferation. Relevant guidelines. The Organ Procurement and Transplantation Network often recommends HLA matching protocols and the use of triple drug regimens for minimizing rejection risks. Compare and contrast hyperacute and acute rejection in terms of pathophysiology, timing, and clinical management strategies. Answer: hyperacute rejection. Timing: minutes to hours post-transplant. Pathophysiology: mediated by performed antibodies e.g. anti-A-TLA or anti-ABO, leading to complement activation, endothelial damage, and thrombosis management. Prevented by cross-matching tests e.g. complement-dependent cytotoxicity test and ABO compatibility. Treatment is largely unsuccessful once initiated, necessitating graft removal. Acute rejection. Timing: weeks to months post-transplant. Pathophysiology: T-cell activation, direct and indirect pathways, and donor-specific antibody production lead to cellular and humoral damage management. High-dose corticosteroids for cellular rejection, plasmapheresis, or IV immunoglobulin for antibody-mediated rejection. Relevant guidelines. The Kidney Disease Improving Global Outcomes KDIGO guidelines outline rejection management protocols, emphasizing early biopsy to confirm rejection type. Sarah, a 45-year-old kidney transplant recipient, presents with rising creatinine levels 3 months post-surgery. She reports adherence to her tacrolimus regimen. Biopsy reveals interstitial inflammation and tubulitis. What is the likely diagnosis and how should it be managed? Answer: diagnosis: acute cellular rejection ACA. Biopsy findings of interstitial inflammation and tubulitis are hallmark features. Rising creatinine levels suggest impaired graft function. Management: immediate treatment. High-dose corticosteroids e.g. methylprednisolone monitoring. Serum creatinine levels and repeat biopsies. Adherence assessment. Confirm tacrolimus trough levels to rule out subtherapeutic dosing. Relevant guidelines. KDIGO guidelines recommend steroid pulses as first-line therapy for ACR and a reassessment of immunosuppressive regimens. What are the common biliary complications following liver transplantation, and what strategies can prevent or manage these complications? Answer: complications: bile leakage, often at anastomosis sites, strictures, secondary to ischemia or rejection, cholangitis, infection of bile ducts, prevention management. Surgical techniques: use of meticulous anastomosis techniques, endoscopic interventions, RCP endoscopic retrograde cholangiopancreatography for strictures or stent placement, prophylactic antibiotics to prevent cholangitis, immunosuppressive optimization to reduce rejection-induced strictures. Relevant guidelines. The American Association for the Study of Liver Diseases (OSLD) highlights early imaging and biliary decompression for suspected complications. Explain the management of electrolyte disturbances in the immediate postoperative period following a kidney transplant. Answer: key electrolyte issues: hyperkalemia due to impaired graft function or delayed graft function (DGF), managed with potassium binders, insulin glucose infusions, or dialysis. Hypocalcemia due to hyperphosphatemia or secondary hyperparathyroidism, treated with calcium supplements or phosphate binders. Hyponatremia associated with overhydration and managed through fluid restriction monitoring. Electrolytes and renal function should be closely monitored, adjusting diuretic therapy accordingly. Relevant guidelines. KDIGO provides recommendations for managing electrolyte imbalances, emphasizing individual patient assessments. A 55-year-old female patient, Mrs. Thompson, is being evaluated for a liver transplant. She has a history of chronic hepatitis C with cirrhosis and present with no current signs of hepatic encephalopathy. A cardiology consultation revealed mild left ventricular hypertrophy and pulmonary function tests showed moderate restrictive lung disease. She also reports mild shortness of breath on exertion. What would be the next steps in her evaluation process considering the multidisciplinary team approach and the significance of the results? Answer: a next step should involve a comprehensive assessment of Mrs. Thompson's cardiovascular and pulmonary status. Given her mild left ventricular hypertrophy and restrictive lung disease, further investigation is needed. The multidisciplinary team, comprising a cardiologist, pulmonologist, transplant surgeon, and anesthesiologist, should review her case. Cardiac stress testing should be performed to evaluate her functional capacity and assess any potential ischemic heart disease, while an echocardiogram would help in assessing cardiac function more comprehensively. Pulmonary function tests should be followed up with a high-resolution CT scan to assess lung parenchyma further. These steps are essential to rule out any underlying cardiac or pulmonary conditions that might affect post-transplant survival or recovery. In addition, considering her cirrhosis, hepatologists should review her liver function and determine the Child-Pugh score and MELD model for end-stage liver disease score, both of which will influence her position on the transplant list. What is the role of screening for infectious diseases such as HIV, hepatitis B/C, and tuberculosis in transplant candidates, and how do the findings from these screenings influence transplant eligibility and timing? Answer: screening for infectious diseases like HIV, hepatitis B/C, and tuberculosis is a critical part of the transplant candidate evaluation process. These conditions can significantly affect the outcomes of the transplant, both in terms of the success of the procedure and the risk of transmission of infection to the recipient. HIV-positive patients, the viral load must be undetectable and the patient must demonstrate stable immune function. If these criteria are met, the patient may be considered for transplant, though careful post-transplant management is required. The use of antiretroviral therapy and monitoring of CD counts are essential. Hepatitis B and C. Hepatitis B/C screenings assess the patient's viral load and the extent of liver damage. Hepatitis B positive candidates may require antiviral therapy to reduce the risk of recurrence post-transplant. Hepatitis C, although previously a contraindication, may now be treated effectively with direct-acting antivirals (DULs) prior to transplant, making such candidates eligible for transplantation. Tuberculosis (TB). Active tuberculosis is an absolute contraindication for transplantation. If a candidate tests positive for TB, they need to undergo treatment and be cleared before proceeding with transplantation. Dr. Martinez, a transplant surgeon, is reviewing a potential kidney transplant candidate, Mr. John Davis, who has end-stage renal disease (ESRD) secondary to hypertension. During the evaluation, a nephrologist notices that Mr. Davis has depression and has expressed doubts about the success of the transplant, which could interfere with his recovery. The transplant team has already assessed his physical health, and the patient is physically fit for surgery. How should Dr. Martinez proceed with Mr. Davis' evaluation considering the psychosocial aspects, and what steps can be taken to address his mental health concerns? Answer: in this scenario, Dr. Martinez must involve the multidisciplinary team, specifically the psychosocial experts, to ensure that all aspects of Mr. Davis' health are thoroughly evaluated. Given the mental health concerns raised by the nephrologist, a referral to a transplant psychologist or psychiatrist should be made for a more detailed psychosocial assessment. It is crucial to address Mr. Davis' depression and any potential mental health conditions, as these can significantly impact his post-transplant recovery, adherence to medications, and overall outcomes. Steps to address the mental health concerns may include psychological support, engaging Mr. Davis in counseling or therapy to address his anxiety and doubts about the transplant process. Education, providing him with detailed information about the transplant process, expected outcomes, and the support available to him throughout the recovery. Collaborative decision-making, involving Mr. Davis in discussions with the entire transplant team to help him feel supported and informed. Social worker involvement. A social worker can assist in coordinating mental health resources and ensuring Mr. Davis has adequate support systems in place. How does psychosocial evaluation influence the eligibility of transplant candidates, and what lifestyle modifications are generally recommended as part of this assessment? Answer: psychosocial evaluation is a critical component of the transplant candidate assessment process, as it provides insight into the patient's mental and emotional preparedness for the challenges of transplant surgery and recovery. Transplant recipients must be able to adhere to complex medication regimens, attend follow-up appointments, and engage in behaviors that promote long-term health. A patient's mental health Social support system and lifestyle choices all play a role in determining their eligibility. Mental health considerations. Conditions like depression, anxiety, and PTSD can significantly impair a candidate's ability to cope with the demands of transplant recovery. Candidates with severe mental health issues may require stabilization through therapy, medications, or both before being considered for transplantation. Lifestyle modifications. Smoking cessation. Smoking is a contraindication for transplantation due to the increased risk of infection and poor wound healing. Substance abuse management. Candidates with substance use disorders should be evaluated for readiness to stop using drugs or alcohol. A history of substance abuse may delay transplant eligibility until a certain period of sobriety is established. Dietary modifications, weight management, nutritional support, and alcohol cessation are critical to improving transplant outcomes. The psychosocial evaluation helps ensure that a candidate is emotionally stable, has the necessary social support, and is prepared to comply with lifestyle modifications to ensure a successful transplant outcome. What are the primary roles and responsibilities of each member of the transplant team, and how does the coordination among team members contribute to the overall success of a transplant? Answer: the transplant team consists of several key members, each playing an integral role in the success of the transplant process. Their coordinated efforts are essential to achieving positive outcomes for transplant candidates. Transplant surgeon, responsible for performing the transplant surgery, assessing the suitability of the donor organ, and ensuring that the procedure is done with the utmost precision and safety. Anesthesiologist, manages anesthesia during the surgery, monitors the patient's vital signs, and ensures stable conditions during the operation. They are also involved in post-surgical pain management and sedation. Transplant coordinator acts as the main point of contact for both the patient and the medical team. They coordinate all aspects of the patient's care, including scheduling appointments, facilitating communication among team members, and ensuring the patient adheres to pre- and post-operative instructions. How do ethics committees contribute to the decision-making process in transplant evaluations, and what ethical dilemmas might arise during such evaluations? Answer: ethics committees are often involved in cases where there are complex ethical dilemmas regarding transplant eligibility, especially when a patient's circumstances present difficult questions about fairness, prioritization, and the allocation of scarce resources. These committees provide a balanced review of the medical, ethical, and social considerations surrounding a patient's case. Common ethical dilemmas include allocation of limited resources. Ethical dilemmas can arise when deciding who should receive an organ when there are multiple candidates. For instance, a candidate with a history of non-compliance or lifestyle issues might be at odds with others who are more medically stable. Life expectancy versus transplant benefit. A candidate with a low life expectancy due to comorbidities might be questioned on whether the transplant would significantly improve their quality of life or survival. Cultural or religious considerations. Some patients may refuse certain medical treatments due to their beliefs. The ethics committee must balance respect for the patient's autonomy with the medical necessity of the transplant. What are the key elements of effective multidisciplinary collaboration in the post-transplant care of a kidney transplant patient? Answer: post-transplant care requires a seamless collaboration between several healthcare professionals to ensure the patient's recovery is optimal. Key elements of this collaboration include immunosuppressive management. The transplant team, including the transplant surgeon, nephrologist, and pharmacist, closely monitor and adjust the patient's immunosuppressive regimen to prevent organ rejection while minimizing the risk of infection. Infection prevention. The infectious disease specialist plays a crucial role in preventing post-transplant infections, including monitoring for opportunistic infections and advising on prophylactic treatments. Nutritional support. A dietitian ensures that the patient's nutritional needs are met, taking into account the risks of weight gain or nutritional deficiencies due to immunosuppressive therapy. Psychosocial support. A transplant coordinator or social worker ensures the patient has access to mental health resources and offers support for issues related to adherence to medications and lifestyle changes. What is the role of cardiac stress testing in the evaluation of a transplant candidate, and how does it influence the decision to proceed with transplantation? Answer: cardiac stress testing is an important diagnostic tool used in the evaluation of transplant candidates, particularly for those with comorbid cardiovascular risk factors. The test helps assess the heart's ability to handle stress, such as during surgery, and provides valuable information on coronary artery disease, myocardial ischemia, and overall cardiac function. Indications. Cardiac stress testing is typically recommended for patients over the age of 50 or those with risk factors like diabetes, hypertension, or a family history of heart disease. Results and interpretation. If the stress test reveals ischemia or significant cardiovascular risk, the transplant surgery may be delayed or reconsidered. Further cardiovascular evaluation or treatment, such as coronary angiography or revascularization procedures, might be necessary before proceeding with transplantation. The results of the stress test, along with the info from cardiologists, will determine whether the patient's cardiac health is optimized for surgery and recovery. Why is psychological evaluation a critical part of the transplant candidate evaluation process, and what factors does the evaluation focus on? Answer: psychological evaluation is crucial to assess the mental and emotional preparedness of transplant candidates. The evaluation focuses on identifying mental health conditions that could interfere with the patient's recovery, adherence to medication, and overall success post-transplant. Factors assessed include mental health conditions. Depression, anxiety, PTSD, and other psychiatric disorders are common in patients with chronic illness and organ failure. These conditions must be managed prior to transplant to improve the chances of a successful outcome. Cognitive functioning. Cognitive impairment, which can affect memory, decision-making, and adherence to medical instructions, is evaluated to ensure the patient can participate in their own care. Social support. Strong social support networks are essential to a patient's recovery. The evaluation assesses the patient's family dynamics, caregiving capabilities, and availability of emotional support post-surgery. How does shared decision-making influence the care process for transplant candidates, and what are the primary principles that guide this process? Answer: shared decision-making (SDM) is a collaborative process where healthcare providers and patients work together to make decisions that align with the patient's values, preferences, and health goals. This approach is particularly important in the transplant setting, where patients face significant life-changing decisions. Key principles include informed consent. Patients must have access to complete, comprehensible information about their diagnosis, treatment options, risks, and benefits to make informed decisions. Patient autonomy. SDM respects the patient's right to make decisions about their own care, even if the decision differs from the medical team's recommendation. Communication and trust. Open, empathetic communication is essential to establish trust between the patient and healthcare team, fostering an environment where patients feel comfortable expressing concerns and preferences. SDM ensures that treatment decisions are patient-centered and that the transplant process is approached holistically, considering medical, psychological, and social factors. Explain the role of the nephron in renal filtration and how abnormalities in renal artery and ureter anastomosis can affect kidney transplant outcomes. What are the potential complications that can arise from improper anastomosis? Answer: the nephron is the functional unit of the kidney, responsible for filtering blood, reabsorbing essential substances, and excreting waste products. It consists of a renal corpuscle, glomerulus and Bowman's capsule, and a renal tubule, proximal tubule, loop of Henle, distal tubule, and collecting duct. Blood is filtered through the glomerulus, where substances like water, electrolytes, and waste products are separated from blood cells and large proteins. Renal artery and ureter anastomosis are critical in kidney transplantation to ensure proper blood flow and urine drainage from the transplanted organ. Anastomosis complications, such as stenosis, narrowing, or leaks, can impede renal perfusion or urine drainage, leading to acute kidney injury, graft failure, or infection. Guidelines. The American Transplant Congress (ACA) emphasizes the importance of ensuring correct blood flow and urinary output post-transplant. The National Organ Transplant Act (NOTA) also stresses the need for skilled surgical techniques to minimize transplant complications. Mr. Garcia has advanced cirrhosis due to chronic alcohol use. His ME/LD score has increased over the past few months, and he is now being evaluated for liver transplantation. Explain how the ME/LD scoring system works and why this score is vital in determining his eligibility for a transplant. Answer: the ME/LD model for end-stage liver disease score is a clinical tool used to assess the severity of liver disease and predict the likelihood of survival without a liver transplant. It is based on 3 lab values: bilirubin INR, international normalized ratio, and serum creatinine. The ME/LD score helps prioritize patients based on the urgency of their need for a transplant. A higher ME/LD score indicates worse liver function and a greater likelihood of mortality. Mr. Garcia's increasing ME/LD score indicates the progression of cirrhosis, reflecting worsening liver function. The score ranges from 6 to 40, with patients scoring high receiving priority for transplant. Guidelines. According to the UNOS United Network for Organ Sharing Policy (MELD), scores are used to allocate livers to patients, ensuring that those with the most critical needs are prioritized for transplantation. The National Institutes of Health (NIH) has guidelines for the management of cirrhosis and the interpretation of MELD scores. How does cardiac output regulation differ in heart transplant patients compared to non-transplanted individuals? What are the key implications of this difference in post-transplant care? Answer: in non-transplanted individuals, cardiac output is primarily regulated by autonomic nervous system inputs, sympathetic and parasympathetic, and circulating factors like catecholamines. However, in heart transplant recipients, the transplanted heart lacks innervation from the autonomic nervous system. As a result, cardiac output is less responsive to physiological demands like exercise or stress because the heart cannot adjust its rate and force of contraction through autonomic regulation. Post-transplant care involves managing the denervated heart, ensuring that heart rate and rhythm are properly monitored, and assessing the patient's response to exercise through alternative methods like heart rate variability rather than relying on subjective symptoms. Guidelines. The International Society for Heart and Lung Transplantation (ISHL) provides guidance on managing post-heart transplant patients, emphasizing the importance of careful monitoring for signs of rejection and infection, which are primary risks post-transplant. Discuss the physiological changes in insulin secretion following pancreas transplantation in a diabetic patient. How does this affect the management of blood glucose levels? Answer: pancreas transplantation in diabetic patients aims to restore insulin secretion by providing a functioning pancreas, which has the ability to regulate blood glucose levels through endogenous insulin production. After transplantation, the newly transplanted pancreas should begin producing insulin in response to blood glucose levels, thereby reducing or eliminating the need for exogenous insulin injections. However, early post-transplant complications, such as delayed graft function, rejection, or infection, can disrupt insulin production, leading to challenges in blood glucose control. Additionally, hypoglycemia can still occur due to initial insulin resistance or graft failure, requiring careful monitoring and adjustments in insulin therapy. Guidelines. According to the American Diabetes Association, aid at close monitoring of glucose levels, adjusting immunosuppressive medications, and evaluating the transplanted pancreas function through laboratory tests are essential in post-transplant care. You are a transplant nurse involved in a public awareness campaign about organ donation. What strategies would you recommend to dispel myths and encourage individuals to register as organ donors? Answer: a successful public awareness campaign should focus on educating the public about the facts of organ donation, emphasizing its importance and addressing common misconceptions. Key strategies include personal stories and testimonials. Share real-life experiences of transplant recipients and donor families to create emotional connections. Clear and transparent information. Provide easy-to-understand facts about the safety, ethics, and life-saving impact of organ donation. Partnerships with community leaders. Collaborate with faith-based organizations, healthcare providers, and influencers to reach diverse populations. Addressing myths. To actively correct myths such as organ donation is only for the rich, or doctors won't try to save your life if you're a donor. Guidelines. The U.S. Department of Health and Human Services recommends public education through media campaigns, school programs, and collaborations with transplant organizations like Donate Life America, focusing on changing attitudes toward organ donation. Mrs. Taylor, a kidney transplant recipient, presents with fever and chills. Her lab results show elevated white blood cell count and decreased kidney function. What steps should you take to manage the potential infection while considering her immunosuppressive therapy? Answer: Mrs. Taylor's symptoms raise suspicion for an infection, which is a major risk following kidney transplantation due to immunosuppressive medications. The first step is to isolate the patient and initiate broad-spectrum antibiotic therapy while awaiting culture results. It's crucial to monitor her kidney function closely, as some infections can worsen renal impairment. Additionally, adjustments to immunosuppressive therapy may be necessary based on the infection type, as some infections are more common with specific immunosuppressants. Reducing immunosuppressive doses during infection can improve immune response, but must be balanced with the risk of acute rejection. Guidelines. The American Society of Transplantation advises that post-transplant patients should receive regular screening for infection and that antibiotic prophylaxis should be considered during high-risk periods. Immunosuppressive management protocols must also be tailored to minimize infection risk without compromising graft survival. How does portal hypertension affect liver transplant patients, and what are the implications for pre- and post-transplant care? Answer: Portal hypertension, often caused by cirrhosis, results in increased pressure in the portal venous system, which can lead to varus or bleeding, ascites, and hepatic encephalopathy. In liver transplant recipients, portal hypertension may persist post-transplant, requiring close monitoring and management. Pre-transplant, patients are evaluated for the severity of portal hypertension, including imaging studies and measurement of hepatic venous pressure gradient (ECG). Post-transplant, careful management of fluid balance and monitoring for signs of graft dysfunction or rejection are critical. Guidelines. The European Association for the Study of the Liver (EASL) provides guidelines on managing portal hypertension, including the use of beta blockers to prevent variceal bleeding and liver transplant evaluation protocols to ensure timely intervention. What are the challenges in oxygenation and ventilation in heart transplant patients, and how can post-transplant nurses address these challenges? Answer: heart transplant patients often experience ventilation-perfusion mismatch due to denervation of the transplanted heart and the effects of immunosuppressive medications. Additionally, postoperative pulmonary edema, atelectasis, or infection can impair oxygenation, necessitating vigilant respiratory support. Nurses should closely monitor oxygen saturation and arterial blood gases, administer supplemental oxygen as needed, and implement pulmonary hygiene techniques such as intensive spirometry and deep breathing exercises to prevent complications. Guidelines. According to the International Society for Heart and Lung Transplantation, routine monitoring of respiratory function is essential, as well as early intervention to treat rejection or infection. Discuss the challenges in glucose regulation following pancreas and islet cell transplantation. What are the key factors that affect blood glucose control? Answer: following pancreas and islet cell transplantation, the main challenge is restoring normal glucose metabolism. While pancreas transplants provide an endogenous source of insulin, early graft function may be delayed, leading to periods of hypoglycemia or hypoglycemia. Islet cell transplants often face the issue of limited islet cell survival, with many patients requiring supplemental insulin post-transplant. Factors affecting blood glucose control include immunosuppressive therapy, graft rejection, and infection, which can all interfere with the transplanted pancreas' ability to regulate glucose effectively. Guidelines. The American Diabetes Association provides guidelines for managing glucose control post-pancreas transplantation, stressing the importance of frequent monitoring and adjustments to insulin therapy during the early post-transplant period. Mr. Lee, a lung transplant recipient, has been experiencing nausea and vomiting since his last dose of immunosuppressive medication. What should be your next steps in addressing his symptoms while ensuring effective management of his transplant? Answer: nausea and vomiting can be side effects of immunosuppressive medications such as cyclosporine or tacrolimus, and may also indicate an underlying infection or graft rejection. The next steps would be to review Mr. Liu's medication to assess the possibility of side effects or interactions, monitor for signs of infection or rejection, including fever, increased white blood cell count, or deterioration of lung function. Just immunosuppressive therapy is appropriate, with guidance from the transplant physician, while maintaining a balance to prevent rejection. Guidelines. The American Society of Transplantation outlines approaches for managing medication side effects, advising careful monitoring and adjustment to minimize rejection risk while addressing side effects. Mr. Thompson, a heart transplant recipient, present 6 months post-transplant with symptoms of fatigue, peripheral edema, and arrhythmias. Endomyocardial biopsy shows dense interstitial fibrosis. What is the most likely diagnosis, and what strategies should be employed for management? Answer: diagnosis: chronic rejection leading to cardiac allograft vasculopathy (CAV). Management: prevention: statins to lower LDL cholesterol and maintain optimal blood pressure. Treatment: coronary angioplasty or retransplantation in severe cases. Monitoring: regular echocardiograms and biopsy to assess progression. Relevant guidelines: the International Society for Heart and Lung Transplantation (ISHL) recommends aggressive management of cardiovascular risk factors to delay CAV progression. Describe the role of antibodies in antibody-mediated rejection (AMR) following organ transplantation. How can antibody-mediated rejection be diagnosed and managed? Answer: role of antibodies in AMR. Mechanism: AMR occurs when the recipient's immune system produces antibodies against donor HLA antigens or ABO blood group antigens, leading to complement activation, endothelial injury, and graft destruction. These antibodies may be pre-existing e.g. from prior transplants, blood transfusions, or formed post-transplant. Novo antibodies. Pathophysiology: Complement-mediated inflammation and endothelial injury lead to graft dysfunction. It is often characterized by capillary thrombosis, graft swelling, and impaired organ function. Diagnosis: donor-specific antibodies (DSA) identified through serum tests like Illumine-based assays or flow cytometry. Histology: biopsy shows peritubular capillary CD deposition in kidney transplants, which is a hallmark of AMR. Allograft dysfunction: clinical signs of graft failure including increased creatinine in kidney transplants or worsening liver function tests. Management: plasmapheresis to remove circulating antibodies, intravenous immunoglobulin (IVIG) to neutralize antibodies and modulate immune response. Rituximab, a monoclonal antibody that targets B cells involved in antibody production. Immunosuppressive regimen adjustment to suppress the production of new antibodies. Relevant guidelines: the American Transplantation Society. It provides management guidelines that emphasize early detection and treatment of AMR to preserve graft function. Discuss the differences in the pathophysiology, clinical presentation, and treatment strategies between acute and chronic rejection in heart transplant recipients. Answer: acute rejection. Pathophysiology: primarily T-cell mediated. Acute rejection occurs when the recipient's immune system recognizes the transplanted heart as foreign. This leads to the activation of CD cytotoxic T cells and CD helper T cells, causing inflammation and graft damage. Clinical presentation: symptoms may include fever, fatigue, shortness of breath, and graft dysfunction. ECG changes such as arrhythmias may also be noted. Treatment: high-dose corticosteroids, rabbit anti-thymocyte globulin TAC, or cyclosporine may be used to suppress immune activation. Chronic rejection. Pathophysiology: chronic rejection involves both immune and non-immune mechanisms, with a key feature being cardiac allograft vasculopathy (CAV), a form of coronary artery disease specific to transplant recipients. This leads to progressive fibrosis, narrowing of coronary arteries, and eventual graft failure. Clinical presentation: symptoms may include gradual decline in graft function, arrhythmias, and progressive heart failure. Treatment: management focuses on controlling risk factors for CAV, hypertension, hyperlipidemia, optimizing immunosuppression, and using interventions such as coronary artery bypass grafting, CABG, or retransplantation in severe cases. Relevant guidelines: the International Society for Heart and Lung Transplantation (ISHL) recommends regular heart biopsies and coronary angiograms to monitor for chronic rejection and guide therapy. Linda, a 38-year-old liver transplant recipient, presents with jaundice, ascites, and hepatomegaly 3 years post-transplant. Her liver function tests show elevated bilirubin and transaminases. Biopsy reveals fibrosis and cholestasis. What is the likely diagnosis and how should it be managed in this patient? Answer: diagnosis. The presentation suggests chronic rejection with findings of fibrosis and cholestasis on biopsy. Chronic rejection in liver transplant often leads to a gradual decline in liver function characterized by fibrosis, bile duct loss, and cholestasis. Management: immunosuppressive adjustment. Consider reducing immunosuppressants if the rejection is related to excessive immune suppression. Conversely, increasing immunosuppression may be necessary if chronic rejection is suspected. Management of cholestasis: ursodeoxycholic acid (UTR) may be used to improve bile flow. Liver transplant biopsy: further biopsies to assess the degree of fibrosis and determine whether retransplantation is necessary. Symptomatic support: treat ascites and jaundice with appropriate fluid management and diuretics, and consider TIPS, transjugular intrahepatic portosystemic shunt, if portal hypertension is present. What are the primary cardiovascular risks in kidney transplant recipients, and how should these risks be managed to optimize long-term outcomes? Answer: cardiovascular risks in kidney transplant recipients. Hypertension, often caused by immunosuppressive medications, e.g. corticosteroids, calcineurin inhibitors, or renal dysfunction. Hyperlipidemia, also a common side effect of immunosuppressive drugs, increasing the risk of atherosclerosis and cardiovascular disease. Diabetes, steroid-induced hypoglycemia, and calcineurin inhibitors, e.g. tacrolimus, contribute to the development of diabetes in transplant recipients, further increasing cardiovascular risk. Pre-existing cardiovascular disease: many kidney transplant recipients have pre-transplant hypertension, diabetes, or vascular disease, which may worsen post-transplant. Management strategies: blood pressure control, use of ACE inhibitors or angiotensin receptor blockers, ARBs, to manage hypertension and prevent progression of kidney disease. Lipid management: statins to control cholesterol levels and reduce atherosclerotic risks, glycemic control, management of post-transplant diabetes through diet, lifestyle changes, and medications like metformin or insulin.